Good afternoon, and welcome to the American Nurses Association webinar session, Caring for Veterans, Equipping Nurses to Address Mental Health Needs. My name is Emily Bell, and I serve as the Senior Policy Advisor with ANA. Over the past year, I've had the privilege of leading the Veterans Health Initiative educational programming aimed at improving nursing knowledge related to the unique healthcare needs of veterans. Prior to joining ANA, I spent 16 years as a psychiatric mental health nurse practitioner, primarily caring for active duty service members, retirees, veterans, and military-connected family members, though I am myself not a veteran. Following our Caring for Veterans webinar in May 2025, we received overwhelming feedback that participants wanted to learn more about how to care for veterans with mental health needs, especially for those with a history of trauma. Today, our goal is to provide an overview of those topics and offer specific suggestions, offer specific strategies to empower nurses to address mental health needs in all care settings. We recognize that veterans face distinct mental health challenges shaped by service, sacrifice, and the transition to civilian life. Our role as nurses is to connect with veterans in a way that honors their experiences and supports their healing process. Here are the objectives for today's session. Please discuss the prevalence and types of mental health challenges. Discuss the prevalence and types of mental health challenges experienced by veterans. Identify barriers that contribute to the underutilization of mental health care among veterans. Delineate different types of traumas that impact mental health, substance use, suicide risk, unique to veterans. Describe one therapeutic communication strategy that can be used to establish rapport with veterans. At this time, we would like you to answer a quick Zoom poll so we can learn more about our audience here today. Do you or someone you know, someone close to you, have military experience? You should see a Zoom pop-up poll on your screen to answer this yes or no question. We'll give you some time to answer. And now we are going to share with you the results. As you can see from these results, almost everyone here today knows someone who's served in the military. It highlights the importance of preparing nurses to address the specific healthcare needs of those who have served. I'm honored to welcome a remarkable interprofessional group of veterans as our speakers today. Each of them brings a unique perspective rooted in their military service. To begin with, they will introduce themselves by sharing a little about their background, personal story, and some pictures. The first of our three speakers is Monique Swaby, a registered nurse, a U.S. Navy veteran, and a doctoral fellow with the American Nurses Association Minority Fellowship Program. Over to you, Monique.
Thank you. As she said, my name is Monique Swaby. I am a BSN prepared nurse, a current student at Purdue for the DNP Psychiatric Mental Health Nurse Practitioner Program. I'm also a doctoral fellow with the American Nurses Association Minority Fellowship Program. I am no stranger to trauma. I am a survivor of intimate partner violence as a former military spouse. I experienced the trauma of losing my mother, also a military veteran, at age 5 due to intimate partner violence, and I overcame military sexual trauma while serving in the military. My experiences inspired me to become a mental health nurse practitioner to make a difference by helping others with traumatic experiences. My research focus areas are adverse childhood experiences, mental health disorders among veterans with history of military sexual trauma and intimate partner violence. I have been a registered nurse for 15 years with a diverse background in clinical and leadership roles. Before nursing, I proudly served in the United States Navy as a hospital corpsman, an emergency medical technician for 10 years, where I developed a strong foundation in trauma care, mental health support, and interdisciplinary collaboration. I have supported suicide awareness, military sexual trauma, and intimate partner violence among veterans with participation in road cycling events, half marathons, and triathlons. It's an honor to be here today among distinguished professionals dedicated to advancing mental health care for U.S. veterans. Now, I'm pleased to turn it over to an esteemed colleague, Dr. JoEllen Schimmels, who brings a wealth of experience in psychiatric mental health nursing.
Thank you, Monique. Hello, my name is JoEllen Schimmels, and it's wonderful to be a part of this conversation. I'm a clinical professor at Emory University in Atlanta, Georgia, with clinical practice as a psych mental health nurse practitioner at Spring Health. Most recently, I served in the outpatient mental health clinic at the Veterans Health Administration in Albuquerque, New Mexico. As a first-generation college student, the military was the way for me to fund my education. I lovingly refer to Uncle Sam as the uncle I never knew I needed, helping me navigate an unfamiliar world to pursue nursing. But the military became so much more than that for me. This trajectory deepened my sense of purpose, highlighted the strength found in shared resilience, and showed me how essential calm, compassionate leadership could be, especially in caring for service members and their families. Now I bring over 28 years of nursing experience, including over 22 years of active duty service in the U.S. Army, with deployments to Iraq and Afghanistan, with 18 years of practice as a psychiatric mental health nurse practitioner. My scholarship focuses on military and veteran mental health, PTSD, sexual trauma and trauma-informed care, moral injury, psychedelic-assisted therapies, nursing education, and nurse and organizational well-being. Outside of work, I'm the proud mother of 2 wonderful children and a proud wife, also 2 amazing stepsons, 4 dogs, and I enjoy playing the piano, karaoke, swimming, and spending time outdoors. Among the images that I show you today, the picture on the right here with there's a coin, and this is what's called a military challenge coin, and that's in there. I know it's kind of small, but it's in there with my dog tags, kind of in my daughter's hands and then in my hands. This is what's called the military challenge coin, and challenge coins are a long-standing military tradition that represent unit identity, pride, and camaraderie. They're symbols of belonging and recognition that remind us of the shared bonds of service. I was honored in 2019 to have my coin design selected for Brigadier General Jack Davis's Chief of the Army Nurse Corps coin. And I actually have it here. Hopefully you can see that okay. This particular coin reads, "Anytime, anywhere, always ready," a phrase that continues to ground me in my Army Nurse Corps roots. The challenge of the coin is that when you're somewhere and you pull out a coin, other people are supposed to pull theirs out as well. So coin checking is a pretty common military practice. And with that, I'm delighted to turn this over to Sazha Alexandra Ramos, whose work and experiences are truly inspirational.
Thank you so much, ma'am. It's such an honor to be with these women on this panel. My name is Sazha Alexandra Ramos. I'm a Navy veteran and a licensed social worker. I'm the Vice President of Military and Veteran Affairs at American Addiction Centers, where we serve military veterans and their families in 8 states at the detox, residential, and outpatient levels of care. As an enlisted service member, my rating or specific job in the military was information technology, so a bit of a change from IT to social work. And for the past decade, I've been helping service members, veterans, and their families across access substance use treatment and mental health resources. My journey into this work actually started with my own recovery from addiction. I was prescribed opioids after an injury in the Navy and sought residential treatment. That experience changed the entire direction of my life and put me on a spiritual path. It eventually led me to work with the SAFE Project under Vice Joint Chief of Staff Admiral Sandy Winnefeld, who founded the organization after losing his son Jonathan to an opioid overdose. That experience deepens my belief that there's no one-size-fits-all approach to healing. I believe in multiple pathways to recovery, that people, including veterans, find freedom and purpose in different ways, and that when people recover out loud, it reduces the stigma around getting help for mental health and addiction. On November 8th, I'll be celebrating 11 years of recovery. I'm handing it back over to Monique, who is going to talk to you about the information and characteristics of the veteran population.
Thank you so much, Sasha. Veterans come from a diverse background, but are united by military service, which often includes exposure to trauma, high stress, and family separation. As you see, the U.S. active duty military represents less than 1% of the U.S. population, while veterans make up approximately 7% of the adult population in the U.S. This specialty population has shared experiences of service. This specialty population has shared experiences of service exposure to stressors that create unique health, social, and family needs. Understanding these factors is crucial for designing effective support programs, healthcare services, and policies for military personnel, veterans, and their families. Many U.S. veterans alive today served during wartime, reflecting the historical involvement of the military in major conflicts. This distinction is often requiring more targeted support and services. Among veterans by service era, most current U.S. veterans served in either the Vietnam, post 9/11, or Gulf War era. The demographics of current U.S. veterans has changed substantially over the last couple of decades. As the number of World War II veterans rapidly declined, the post 9/11 veterans represent the most ethnically and racially diverse group compared to previous eras. There's also an increase in the number of women veterans. As you see here, 1 in 8 men veterans, which is about 12.5% of men who have served in the military, while there's only 1 in 100 women who are veterans. This reflects the long history of male-dominated military service. Currently, the median age of U.S. veterans served is 65 years old, with post 9/11 veterans being the youngest group, with a median age of 37 years of age. And World War II veterans being the oldest group, with a median age of 93. Behind every number is a story. So let's take a closer look into the mental health well-being challenges veterans face. Nearly 1 in 3 veterans have a confirmed mental health diagnosis. Depression affects about 15.5% of veterans, while PTSD impacts 9.3%. Anxiety disorders are present in 8.3% of veterans. It is also important to note the high rate of co-occurrence. Many veterans experience more than one mental health condition, and they often alongside have chronic physical conditions as well. For example, among veterans with any mental health diagnosis, 20% are also diagnosed with a substance abuse use disorder. These overlapping mental and physical health challenges highlight the need for comprehensive, integrative care that addresses the veteran's health holistically. According to the Department of Veteran Affairs, military sexual trauma refers to sexual assault or threatening sexual harassment experienced during military service. MST is a serious and widespread issue. Women experience MST more than men do in the military. MST is influenced more by military culture and systemic factors than by combat exposure or deployment. There is a need for systemic cultural change. As a survivor of MST and IPV, I had to learn coping mechanisms to overcome the traumatic events. Cognitive behavioral therapy was instrumental in giving me the tools such as EMDR, which is known as eye movement desensitization and reprocessing therapy, to help me heal from traumatic memories. The most recent statistics available indicate that approximately 17 veterans die by suicide per day. It is considered the 12th leading cause of death in this population. Research indicates that there are recognized gender differences in the way veterans die by suicide. Depression, anxiety, and PTSD are the most common diagnoses of veterans that have died by suicide. This indicates that mood and trauma-related conditions are major risk factors. The high daily suicide rate emphasizes the urgent need for targeted prevention efforts, mental health support, and interventions that address gender-specific risks. Veterans who receive recent care through the Veterans Health Administration experience higher rates of suicide, as well as higher rates of all-cause mortality compared to other veterans. Veterans using VHA services often represent a higher risk population related to socioeconomic, physical, and mental health vulnerabilities. Despite availability of specialty and integrated primary care mental health services, most veterans receiving care within the VA are not receiving treatment to address their mental health needs. Recent research indicates that only 26% of veterans with a probable mental health disorder are utilizing these services. While the VA's integrated care model promotes access, many veterans seek and receive health care outside the VA, making it impossible to track these services that are used across the entire U.S. These findings highlight the need to expand outreach, reduce stigma, and coordinate care both inside and outside the VA's healthcare system. Here's our second Zoom poll. When you hear the word stigma, which group do you think experience it most strongly in healthcare? And please respond to the Zoom poll pop-up that you see on the screen. Okay, according to the poll, the majority of people selected individuals experience mental health illness. When you hear the word stigma, that's the group that experience it most strongly in healthcare. Thank you. Many veterans have a negative perception of seeking mental health services as well as receiving their health care through the VA for various reasons. Men are more likely to delay seeking help for medical concerns, while younger men are more likely to avoid care when compared to women. And women defer from using the VA due to the belief that there is a lack of sensitivity specific to women's health. Cultural norms significantly impact health-seeking attitudes and behaviors. Addressing mental health disease stigmas require education, cultural sensitivity, and systems-level change. I remember hearing the adage that pain is weakness leaving the body. However, there wasn't conversation regarding emotional pain or trauma after witnessing suicide as a first responder or experiencing personal violence in the military. Truthfully, some veterans never overcome the pain of buddy suicide, personal loss, or even the loneliness that occurs after service. They sometimes suffer in silence, which may lead to suicide, depression, anxiety, and maladaptive coping. This concludes my overview of the unique mental health needs of U.S. veterans. Let me now hand it off to Dr. Schimmel, who will lead us into the next part of our conversation on stress, trauma, and PTSD.
Thanks again, Monique. We all appreciate all the information that you presented. So I realize these numbers may sound discouraging, but military service also offers a profound sense of mission, belonging, and purpose. It provides opportunities to serve our country, build leadership, and be part of something larger than ourselves. I've had the privilege of caring for service members in a variety of settings, including during multiple deployments. Deployment environments are often high stress and high risk, where emotional resilience is constantly tested. Access to mental health care can be limited by operational demands, stigma, and confidentiality concerns. Despite the strength and discipline that military life instills, the psychological toll of deployment can be significant. So I chose these photos. I wanted to just kind of give you a smattering of some of my experiences, but most importantly, these really represent the diverse environments where I've cared for service members. And I could have included all kinds of pictures about some of the clinics and hospitals I've been at, but these probably are something that you haven't always seen. So on a cot in the corner of a tent, or in a truck, or here on the lower right-hand side in a bunker, or if I had access to clinical space. This was one of the clinics. This is a picture in Iraq in a sandstorm, but if I had access to clinical space, those were all common places that I would be able to see patients or be able to work with service members in their units. But they reflect the importance of meeting individuals where they are and approaching each person with an understanding and acceptance of their unique journey and experiences. In combat stress units, our mission is to treat as far forward as possible without taking someone out of their unit, identifying needs early, providing crisis intervention and stress first aid, and delivering ongoing support and monitoring. Mental health care extends across the entire deployment cycle, from pre-deployment education and resilience training to in-theater support and unit-based interventions, all the way to post-deployment reintegration services for service members and their families. And trauma isn't just a psychological term. It represents deeply distressing experiences that shape the way that an individual is going to experience. It shapes the way we feel and think and engage with the world. So whether it's a single event or repeated exposure to adversity, trauma influences our emotional, physical, and social well-being. A traumatic event is any experience that overwhelms an individual's ability to cope. This could be something like abuse, violence, natural disasters, accidents, death, a variety of factors that occur before an event, during an event, and also after an event are additionally going to influence an individual's coping. So it's important to remember that trauma is very subjective. What feels overwhelming to one person may not for another. It's the individual's perception and the individual's response that defines an experience as traumatic. And exposure to a traumatic event is what we call criteria A for the diagnosis of PTSD according to the DSM, or the Diagnostic and Statistical Manual of Mental Disorders. So military service is defined by honor, sacrifice, and resilience, but it also exposes individuals to experiences that can profoundly affect their mental and emotional health. Service members face unique stressors such as combat, operational demands, harsh environments, frequent relocations, moral injury, and survivor's guilt, all of which can impact readiness, performance, and well-being. And military culture includes rigid hierarchies, the chain of command, high performance expectations, and inconsistencies sometimes between training and mission that can further shape how stress is experienced. Concerns about confidentiality and career impact may deter individuals from seeking mental health support. And unlike in civilian workplaces, commanders are deeply involved in both the professional and the personal lives and aspects of service members. So it places them in a key role to influence a unit's mental health climate. Leadership that fosters trust and openness and psychological support really can serve as a protective factor against stress. As in my work in combat stress and throughout my military service, I encouraged commanders to come in and really wanted them to be, to be seen talking to me regularly for their own mental health, but also just to show service members that it's okay to talk to someone. I even had some commanders schedule with me just so their troops would see them coming in. And I've worked with commanders to deliver education, training, needs assessments just to see what's going on in their unit and what some of the needs might be in their unit, and individual evaluations, including what are called fitness for duty assessments that may impact deployment and career progression. And then while the military provides a strong sense of identity, structure, and community, the transition to civilian life can also be very challenging for veterans, adjusting to that loss of support and shared purpose. So not all service members suffer from post-traumatic stress disorder or PTSD, but as Monique mentioned, PTSD is a significant mental health concern within the military and veteran populations. Since PTSD is triggered by exposure to a traumatic event, that can be potentially heightened by the things that I just discussed on the last slide in the military and veteran population, it really is crucial to understand the symptoms that impact daily functioning. So I'm going to have everyone close your eyes. Take a deep breath in. Picture this. You're standing in the grocery line, thinking about dinner, and out of nowhere, you think you hear gunfire. Your heart is racing so fast you can hear it in your ears. The edge of your vision begins to blur, and it feels like the air has gotten thicker. No matter how deeply you try to breathe, you just can't get enough air in. Your palms are thick with sweat, and your legs feel weak. A wave of heat crawls up your neck, followed by an icy chill. Are you having a heart attack? Are you dying? The sounds of the store fade into a muffled hum, and your body feels foreign to you, like you're watching yourself from somewhere else. Imagine not being able to trust your thoughts, feelings, and physical sensations. Open your eyes. So these are the 4 symptom clusters that make up the other criteria outside of an actual event for a PTSD diagnosis. So keep in mind, PTSD is not just symptoms. It's also characterized by duration and clinically significant distress or impairment in important areas of functioning. So I'm not teaching you how to diagnose, but to really recognize these symptom clusters and to give you tools to talk to veterans and to all patients so you can feel more comfortable moving through recovery with them. Our brains are remarkably adaptive, often trying to protect us even when it causes distress. In PTSD, the brain's efforts to help can actually produce these symptoms that are listed on the slide. One fascinating aspect of how our brain works is that it can function across time, right? It can function in the past, present, and future all at once. I can think about what I did last week, and I can look forward to what's going to happen next month. A current trigger may prompt a response that's rooted in a past experience or in anticipation of something feared in the future. So because trauma and traumatic memories are often fragmented or distorted, the brain may react to just part of an event or a very specific detail that might be a very vivid detail of an event rather than considering the whole situation. The brain may also react to the meaning that we've attached to something. Thoughts like, it was my fault, it shouldn't have happened, I should have done more. Those cognitive distortions shape how trauma and individual identity are perceived. Processing is not about forgetting. We're not here to try to talk any veteran or any patient into forgetting what's happened and the things that they've been through. It's about making sense of things that often are very senseless. So making sense doesn't mean that it's okay. It's about learning to function in the present tense to transform trauma into understanding and purpose. And we can appreciate that the brain's intention is self-protection. But as you can imagine, veterans may have gotten very good at their survival response, right? In that stress response, that survival response, that fight or flight. It increases alertness. It prepares you for something bad that could happen. Who doesn't want to be prepared if something bad might happen, right? This sounds good, but awareness of the body's internal and awareness of the external world are often dysregulated when it comes to PTSD. So that distorts the ability to accurately perceive and interpret internal and external cues. And this includes misinterpreting something like a normal increased heart rate as maybe a sign of danger. Noticing thoughts, noticing the body and the environment helps bring the nervous system into more of that parasympathetic, that calmer state. Treatments can be categorized from a bottom-up approach, so where we use the body to signal safety in the mind, or from a top-down, which is where we target the mind and how we interpret things to direct the body's responses. And by engaging the senses and calming the nervous system, patients can learn to shift from that sympathetic fight or flight, that stress or survival response, to a more parasympathetic state, promoting relaxation and emotional regulation. You can also remind patients that conflicting emotions can coexist. I can be both brave and vulnerable at the same time, even though those seem like opposites. I can be both safe and scared at the same time. A term I like to use is skited, scared and excited. Sometimes until we look at how we interpret the body's sensations, we're the ones putting that label on things. So I can also desire closeness from my loved ones, but I can want to be alone and need alone time. The first cluster, intrusion. So things like re-experiencing, flashbacks, nightmares, these symptoms actually help remember the worth of the loss. Our brain wants to kind of shove those reminders out there because our brain wants, because this was impactful to us, our brain wants to remember. But in veterans, as you can imagine, or anyone with PTSD, this could seem disorganized or distrustful or on edge. Avoidance. So things like steering clear of reminders. As you can imagine, trying not to think about things or avoiding places that might be triggering, those probably help you feel safer. Removing yourself from a situation that you don't like or that you feel uncomfortable in, or not thinking about things that are distressing. In the short term, that could help you feel better. But veterans, or again, anyone suffering from PTSD, could look very quiet or passive or even aloof or disengaged. Negative alterations. Negative changes in thinking and mood, things like guilt and emotional numbness. And this is really, our brain, again, wants to make sense of things. When something doesn't make sense, our brain wants to put it in a place where it makes sense. And sometimes when it doesn't, we'll create these negative changes in how we think about the world to make it fit. But if you can imagine, people with PTSD might look depressed, withdrawn, or apathetic. And the last symptom cluster, hyperarousal or hyperreactivity, things like startle response and irritability. This is to keep you on guard. This is kind of where I started the conversation is, if this is not a bad thing, that we're prepared if something, for something bad to happen, and that we're kind of using that, to help us feel ready and feel secure and almost feel safe that we're ready in case something happened. But as you can imagine, in veterans or anyone suffering with PTSD, this can look anxious, hostile, angry, or argumentative even. What matters most in working with trauma survivors in general is cultivating therapeutic alliance and offering comfort with curiosity. So the trusting, compassionate connection between the nurse and the patient. This relationship is the foundation of healing. And across evidence-based PTSD treatments, there's several key elements that are consistent. That's psychoeducation, emotional identification and regulation, exposure through guided engagement, identification and restructuring those cognitive distortions that I just mentioned, and reorganizing or kind of trying to make more sense of traumatic memories instead of focusing on just little slivers. Nurses can support veterans through these processes by promoting regulation and safety. Emotional dysregulation can be very frightening, but a broad range of emotions is very normal, and it's a normal part of recovery. But our goal is connection, to provide structure and support so veterans can stay grounded and helping them stay engaged without becoming overwhelmed. So ultimately, our role as nurses is to meet patients where they are, to understand these symptom clusters, and offer education, practical, compassionate strategies that promote safety, regulation, and trust. The first symptom cluster, re-experiencing, some of the things that have been found to be helpful are different types of exposure and controlled engagement to triggering cues that really can help people process intrusive memories. So things like grounding, distraction, using movement, breathing exercises are particularly effective for managing re-experiencing symptoms by helping people connect with the present tense. Like I mentioned earlier, we can be in that past, present, and future at the same time, but we're helping people connect with the present tense. So one technique that can be helpful is encouraging patients to notice specific physical sensations. So something like their feet on the floor, their butts in a chair, the presence or pressure of their body, how their body feels in a chair. Focusing on very concrete, descriptive observations rather than general feelings. I don't feel good or I feel uneasy. Instead, shifting that to, I notice that my feet feel heavy on the floor. These grounding strategies can help patients reestablish contact with the present, reducing distress from intrusive thoughts or memories. Avoidance. So while avoidance can provide short-term relief, as I mentioned, it becomes problematic when individuals, as you can imagine, taking like a rucksack, it's a pack or a pack of some kind, and just kind of packing all these unprocessed memories and thoughts and images, packing them in there real good. But the rucksack becomes too full. It might even be splitting at the seams, leading to becoming emotionally overwhelmed or sudden symptom escalation, which seems like out of nowhere. Gradual exposure and reconnection with feelings and bodily sensations can help reduce avoidant patterns. However, it's important to note that these might not be all that effective if people are practicing them in those moments of acute distress or crisis, especially when veterans have become so good at that survival response. Sometimes if they want to practice those when they're really amped up, they might be not as effective as you can imagine, and then they're potentially going to give up on some of those techniques. So you really want to be practicing these things and get better at that parasympathetic, that calming response, because we don't need to work that survival response muscle anymore. But one technique is beginning with less distracting situations to build success, reinforce progress, and enhance a sense of control. Identify practical ways to reduce stress while still engaging with life is going to be critical. Things like maybe finding a time, instead of going right after work, where a lot of people might be shopping, maybe find a later time when there's not as many people there. Choosing specific locations in public spaces, like looking at where you're sitting in a movie theater or where you're sitting in a restaurant, rather than not going out at all, finding things that might, be not as triggering for you. Because avoiding things entirely, again, is going to cause problems later. So this approach allows patients to gradually confront challenging situations at more of a manageable pace, fostering confidence and adaptive coping over time. Negative alterations. So negative beliefs and distorted cognitions can often be addressed through cognitive restructuring. One helpful exercise is cognitive grounding. A useful illustration is the bus metaphor, and this actually comes from acceptance and commitment therapy. In this metaphor, the individual is the driver of the bus. So the bus represents you being the driver, and the bus represents your life and your direction. And then the passengers on the bus are your thoughts, feelings, and memories. They may vary from being very pleasant to critical or to distressing. So the key is to recognize that while the passengers might be loud and very distracting, they can't take the wheel. You have the wheel. This metaphor reinforces the idea that thoughts and memories don't control behavior, that the individual does. And in practice, this could be paired with grounding statements to reorient the veteran to the present moment. Things like, you're safe now, that's a memory, this is not the present. You are here in this clinic, this hospital, this unit. I'm Ellen, I'm the nurse working with you. This approach helps veterans regain a sense of safety, agency, and present moment awareness, really reducing the power of intrusive or distressive cognitions. And then hyperarousal. So hyperarousal, breathing and sensory regulatory exercises can be really helpful. One technique, there's all kinds of different, I like to use a lot of metaphors, but I actually have a stack of fake like origami money, and I've made an origami boat. Hopefully you can, I'm actually pointing the wrong way. Hopefully you can see that. So thinking about taking paper, and you could use this, a piece of paper or something like origami money, and folding it, thinking about what that would feel like in your hand, making the creases and other things like that, and then taking that boat and visualizing it, maybe putting it on the table, even on your hand, and thinking about even blowing it. So imagine this gentle boat ride. This helps encourage calmness, and it can also reinforce those breathing exercises. Another common imagery used is like a cupcake and a candle. So thinking about a cupcake, what would it smell like? Anticipating what it will taste like. What would my cupcake look like? What kind of sprinkles does it have on it, or what kind of frosting? And then it's got a candle on it, and think about what it would take to blow that candle out, or blow that boat across the water, or even a cup of water or a bowl. But you want to focus attention on a sensory risk soothing mental image that can help regulate arousal, or something like holding a token. I had showed this earlier. A lot of veterans carry some of their challenge coins with them. That might be something that means something to them that you can ask them about. Do they wear pins or something that they could use as kind of a grounding token? Use metaphors, or using metaphors that can help, but using the grounding, something like a grounding token, something like a challenge coin that they might already have or be more familiar with. But brief interventions, also like applying ice packs to the cheeks or under the arms, can also help the calming reflex. But these exercises can help retrain the stress response, improving resilience, and reducing hypervigilance over time. And as Monique mentioned earlier, beyond PTSD, veterans also have high rates of depression, anxiety, substance use, and are at higher risk for suicide compared to the general population, with risk particularly elevated among those with PTSD, chronic pain, and traumatic brain injuries. Trauma-informed care is an approach that acknowledges the widespread impact of trauma and emphasizes physical, psychological, and emotional safety. It helps survivors build a sense of control and empowerment, and enhances therapeutic alliance, and really is just good nursing care. So understanding that people have experienced trauma, what these experiences might look like, and how this might affect their behavior, their health, their engagement with care. Earlier, I mentioned that veterans could look aloof or angry or disconnected, but being aware of where this could be coming from is really helpful. So nurses can work with these patient presentations with empathy and understanding. So the core principles are listed here, things like safety. So looking at how you provide safety, emotional and physically, being open and honest about care and treatment, and trustworthiness, building trustworthiness in general, offering support and collaboration, so working with veterans, not on them, empowerment, and really honoring autonomy and strengths that people bring to the table, and inclusivity, which is recognizing identity and background, culture, and that includes military service and veteran status. And Sazha will review more about how to ground these factors into caring for veterans next. And I just wanted to mention the Have You Ever Served campaign. So asking, have you ever served, is one question that helps identify individuals who may require tailored services, screening, or resources. It validates experiences and helps people feel recognized, respected, and heard. This lays the foundation for patient-centered care that addresses a veteran's unique military experiences while building that therapeutic alliance. The www Have You Ever Served site, which is listed here, provides free pocket cards and resources for understanding veteran medical and mental health issues. And by providing timely, accessible, and trauma-informed treatment, we honor the humanity of those who have served. Every conversation, every moment of compassion, and every act of support can make a difference in saving a life, restoring resilience, and ensuring that no veteran suffers in silence. And I'm excited to pass this to my colleague, Sazha Alexandra Ramos.
Thank you so much, ma'am. That question is so important because it's where we start. And when we don't identify if the patient is a veteran, we can't go to the next step. So what's the next step? When you identify that a patient is a veteran, that becomes an opportunity to connect with someone who has lived through a unique set of experiences that shape their identity. Veterans, like my colleagues here, have shared their stories of service, transition, and resilience. And as providers, we have the privilege to create a space where those stories can be safely shared. I would like to introduce to you Dr. Joe DeRacy's work. He has been a mentor in my life, a licensed psychologist at the VA in Vision 2, and an Army infantryman and lieutenant colonel. His work on the modern warrior's journey breaks down a veteran's transition into 3 stages: departure, initiation, and return. This work is based off of Joseph Campbell's Hero's Journey, and at each stage, it involves a helper. As healthcare providers, we are that helper during the return. Our role is to help veterans make sense of their experiences and find new meaning. Military culture shapes communication styles. So, like Dr. Ellen said, veterans may appear formal, reserved, or direct, not because they're cold, but because clarity and respect are ingrained in their training. This isn't just about a yes, ma'am, or a no, sir. It's an internal code of discipline that we're trained for: accountability and structure. When that structure disappears after service, uncertainty in civilian life can trigger frustration or withdrawal, and understanding this helps us meet veterans where they are without taking their tone or demeanor personally. Power dynamics also play a lasting role. In the military, there's a clear distinction between officers and enlisted service members. Officers often serve as leaders, or in many cases, healthcare providers themselves. Enlisted personnel are trained to defer to those in authority. For example, an enlisted veteran might hesitate to question a provider's recommendation, while a former officer might assume a more directive or collaborative stance, as officers were usually in charge of junior soldiers or sailors, and input was often required from them. Recognizing these underlying dynamics allows nurses and providers to build balanced, respectful relationships that empower the veteran as an equal partner in their care. Therapeutic communication is purposeful, professional communication designed to support a patient's emotional and psychological needs. Every conversation should have a goal, whether to build trust, assess readiness for care, or explore feelings about treatment. Key strategy number 1, meet them where they are. Many veterans can manage pain, trauma, or transition through coping mechanisms that may not seem healthy from the outside, like substance use. Instead of judging those behaviors, we can approach them with curiosity. What purpose is this serving right now? In my own recovery journey, I've experienced how much this kind of compassion matters. The first person I ever told that I was struggling with opioids was a nurse, my sister. You might have a sibling or a loved one who holds that kind of space for you. My sister, also my best friend, just happens to be a nurse. When I think back to that moment, what made it possible for me to open up to her in my moment of despair and shame wasn't her clinical knowledge. It was her presence, her compassion, and the way she listened without judgment. Now being in recovery for almost 11 years, this conversation became the doorway to healing, and it began with a nurse who simply chose to be present. Active listening and nonverbal communications. Veterans are trained to notice everything: tone, body language, inconsistencies. They'll know if you're distracted or disinterested. A helpful acronym is SOLAR: sitting squarely facing the client, open posture, leaning toward the client, eye contact, and a relaxed posture. This becomes especially important when working with veterans who have PTSD or trauma histories, avoiding postures that may appear threatening, crossed arms, standing over them, or sudden movements. Using reflection and clarification. When a veteran says, "I hate taking my meds, they make me tired," you can reflect back to the veteran, "You've stopped taking your medications because the side effects are difficult. Is that right?" That one question, you can build safety and trust. Empathy and validation. Acknowledging a veteran's vulnerability, especially when they open up about trauma or addiction, validates their humanity. Empathy just isn't feeling sorry, it's standing alongside, next to someone in their experience. Veterans often feel they must suck it up or stay strong, even when they're suffering. That mindset can make vulnerability feel unsafe and uncomfortable. When you show empathy, you challenge that belief and open the door for healing. Empathy leads to hope. Even if they're not ready for treatment, you can still plant the seed. Have you ever thought about recovery? Or, I believe in a recovery for you. Now on to de-escalation techniques. De-escalation isn't just a crisis skill, it's a continuation of therapeutic communication. When a veteran is in distress, tone, posture, and words communicate safety or danger before anything else does. Veterans, again, are trained to scan for threat. Their nervous systems are finely tuned to pick up cues. If we raise voices, move abruptly, or seem dismissive, the veteran's brain can interpret that as danger, triggering a fight or flight or freeze response. And once that happens, reasoning and connection can become nearly impossible. So why does de-escalation matter? When de-escalation fails, the veteran may leave feeling misunderstood or unsafe and might avoid healthcare altogether in the future. It can reactivate trauma, especially for veterans with PTSD, where perceived threat mirrors experiences from combat or crisis situations. Escalated encounters can also lead to seclusion, restraint, or law enforcement involving reinforcing distrust in healthcare systems. Every escalation that ends without a safety reestablished is another story a veteran tells himself, this is why I don't get help. So the grounding approach to this is, again, maintaining non-threatening body language, standing side to side rather than head on, keeping your hands visible and relaxed, using a calm and even tone. Slow speech communicates control, acknowledging feelings. I can see that this is really frustrating for you. Let's take a breath together. Offering clear choices. Predictability restores a sense of control, and adjusting the environment. So lowering the lighting, minimizing background noise, ensuring exits are visible. Remember, de-escalation is trauma prevention. It protects both the patient, the provider, and preserves the possibility of continued care. When we de-escalate with respect, we're not just calming a situation, we're rebuilding trust one interaction at a time. Military culture is its own identity, and veterans come from all racial, ethnic, and social backgrounds, just like Monique had said earlier. Research by Patrick et al. Found that only 16% of civilian healthcare providers have any military experience or training in veteran cultural competency, and that's a gap that we can fill. Cultural competency involves 3 domains: awareness, knowledge, and skills. And ways to build that competency are taking free trainings through PsychArmor or VA's evidence-based competency programs. Your facility can also become a PsychArmor certified facility, which means that 80% of your staff has been trained to work with veterans. Attending veteran events, especially with Veterans Day coming up on November 11th, organizations like Team Red, White, and Blue offer community-based wellness programs where providers can show up as themselves and engage directly with veterans. Now, before we go into providing care, we must reflect on our own biases. Let's start with 2 separate questions. What are some positive assumptions you've heard about U.S. veterans? I see dedicated, strong, hardworking, resilient, patriotic. Lots of good, positive qualities. Now we'll go into negative assumptions. Extreme, unstable, angry, rigid, crazy, hard to get along with. And this activity isn't about judgment, it's about awareness. Bias lives in all of us, and shaped by culture, media, and experience. Therapeutic communication requires us to check our assumptions at the door and meet the veteran as a unique individual. Reflective practices like mindfulness, coalition building, and self-audit help reduce the harmful effects of implicit bias in the clinical environment. Thank you for everyone who is participating in that bias activity, getting a lot of responses. How veterans can access care. Navigating the VA system can be overwhelming. Nurses play a key role in helping veterans understand their levels of care. Levels of care are outpatient services where veterans can attend scheduled therapy, med management, or group sessions while living at home. Inpatient services, 24-hour medical and behavioral care for veterans needing stabilization, detox, or intensive support. Crisis intervention services, immediate assistance when a veteran presents in acute distress, often through emergency department or crisis teams. Key resources are the Veteran Crisis Line, where you can dial 988, then press 1. If you're working with a veteran, you can sit with them while they call. Your presence is important and matters. Military One Source, which is a confidential counseling and transition resources. In Transition, helps service members and veterans stay connected to mental health care during changes. Vet Centers, which is readjustment counseling for combat vets and families. VA Substance Use Disorder Locator, where you can find VA programs offering addiction services. And the My Health eVet portal, one of my favorite tools to use, enables veterans to message providers directly, and this is often reviewed by a nurse within 48 hours, reminding veterans that these systems were built for you. Additional free resources are the PTSD Coach app, the VA Stress Management Workbook, which is downloadable and easy to use. The Shared Decision-Making Toolkit empowers collaborative care between nurse and veteran. And the ANA Caring for Veterans website, which is coming in 2026, a national hub of training and support resources for nurses. In closing reflection, when providers meet veterans with presence, respect, and compassion, we can help them along their healing journey. I've seen this in my own life. The first person who held space for my recovery, a nurse, my sister, who has always offered a space of non-judgment, compassion, and empathy. We are now going to transition into the question and answer portion of the webinar.
We extend our sincere appreciation to the interprofessional panel of veteran leaders, Sazha, Ellen, and Monique, for their insightful presentation today. Thank you for generously sharing both your professional perspective and personal journey. It has been truly impactful. We are now going to transition into the question and answer portion of today's session. All right, so the first question here is for JoEllen. What is the most effective way to support veterans during transition from military to civilian life?
Thanks. Well, that's a great question. Honestly, for nurses, the most effective way to support veterans transitioning to civilian life is to lead with connection, curiosity, and then I think that a lot of resources were mentioned here, and to kind of know where those resources are located, where some resources are located, and really look at how aware you are of connection and how to connect veterans, if nothing else, if how to get them somewhere where they could find out more information. So honestly, connection, it's the thing about veterans a lot of times is that they're not just losing a job, they're losing a team and an identity. And so as nurses, we're really, I would say, uniquely positioned to build trust quickly. I think we've been the most trusted profession now for like 23 years. So asking about have you ever served, listening without assumptions, recognizing that service is a strength that they have, even if they have some negative thoughts about their service, or as they reflect on things, really have some doubts. That's still something that you want to kind of create as a strength of theirs. That really is going to help create strength and safety, I should say, safety and belonging. And I think the curiosity, again, it's not just a career shift, it's not just this shift. If you're talking about a cultural transformation and an identity transformation, nurses really can help normalize this process. This is scary. I can imagine that you've lost a lot. So helping them articulate what their strengths are, validating really the emotional weight of getting out of the service, and then maybe even the emotional weight of adapting to this community that they feel like they don't have, or that doesn't understand them even. And so really asking them where they want to go next, and what they want to talk about that process, and kind of helping them reconnect with some purpose in their life. And then, webinars like this are so helpful for just learning about those coordination. I think nurses are naturally very good at coordinating, finding resources, using resources. So I would say continue to kind of build your own list. If you don't have a list for wherever you're at, maybe you could start a list like that. That is something that could be available to anyone who needed to refer veterans to any kind of resources.
And our next question here is for Monique. On October 29th, a senator introduced a bill to form a commission to evaluate the current compensation rates of VA disability. What action steps can we take as nurses to advocate to ensure that veteran benefits are not shipped away from them if this bill is passed?
Thank you for that question. One thing that's very important as nurses is to reach out and converse with your elected officials. Make sure they know who you are. Make sure that they know that you are a veteran and that you also are a nurse, and that you're available to assist the office with research information or just spreading more information. The other thing is empowering the veteran themselves to make sure that they understand that any injury or illness that occurred while on active duty, or that even occurred before service but was worsened during active duty, is eligible for compensation for disability. So just making sure they understand that they can go to what we call veteran service organizations that can help them with their claims, and to make sure that they get their military medical records and stay on top of that, and then file for disability. That's the biggest part, because if you don't file for any disability, you can't get into the VA for care, or if you do, it's a very big struggle. So I just ask people, number one, to go to medical, encourage your family members, if they're serving, to go to medical. There's a saying that, just suck it up and keep going, but that's not true. You need to go to medical if you have signs of, like migraines, backache, knee, feet pain, foot pain. Go to medical, get it documented so that when you get out, you can get a compensable rating and get compensated as well. So that's my answer, just to continue to converse with your elected officials and make sure that veterans know that they have the right as well to converse with their elected officials. Thank you.
Thank you, Monique. The next question here is for Sazha. What role does the government shutdown play in availability for services through the VA and other organizations that serve our service members and their families now and in the future?
Thank you for that timely question. Right now, from my experience, we have not been seeing a delay in veterans getting care at the VA. I think long term there can be some effects, specifically with cuts. But we have been notified that those that are in healthcare at the VA are still continuing to serve veterans.
And the next question we have here is for JoEllen. They write, my understanding of military OneSource is only for active duty or up to a certain period of time post-discharge, such as 30 days.
Yeah, that's a great question. So I know Sazha gave a lot of resources, and that's part of this initiative really, that ANA is going to have a page where other resources are available and other ways that you can connect. Military OneSource as a specific resource is available for 365 days, so a year, but I still understand what you're saying. It's limited in that sense. But military OneSource is limited even for active duty as well, because it really isn't meant to be like an ongoing therapy or anything like that. So it's something that is one of the resources that's available. Yes, it's time limited, but there are so many other resources available that I just wanted to mention that.
And the next one here is for Monique. Are there differences in approach when connecting with veterans from different generations? For instance, the Vietnam era versus post 9/11.
Thank you, Julie. As a nurse, while I worked in the VA, I actually took care of Vietnam veterans versus younger veterans. And what I learned was they all want to be heard. They all want to be respected, regardless of their age or what time period they served. So usually I try to build a rapport with them. I ask them about their service. What did you do in the military? And that usually opens up the dialogue. And then I offer self, what can I do to help you on today? When I'm conversing with them, I'm not typing on the computer, not looking at them. I stop. I actually face them so that they know that I'm actually listening to what they have to say. So those are just little tidbits that I learned while working in the VA to help build rapport with veterans of all ages. Thank you.
And the next question here is for Sazha. Is it better to assist a patient with mental health needs to VA versus the traditional healthcare system?
Great question. I would ask the veteran first, what's their experience with the VA? And from there, you can gauge if they are, they know how to go through the VA system, what were their experiences in the past. If they came to you in the civilian setting, it may be because they've had a poor experience or they don't know how to navigate that system. So I would start there, and then guide them based off of their answer.
Thank you. The next question here is for JoEllen. How can nurses build trust with veterans who have experienced trauma or institutional betrayal?
Yeah, that's a great question. I think that, we've talked a little bit about this, really expanding on that trauma-informed care. I don't want to sound like a broken record, but I think what we do to really help empower them to talk about their experiences and to really help normalize that you've been through a lot of things. How to, of course, you're going to have some of these thoughts, but how can we, bring to the present tense as well, in the sense of, how do we, what does moving forward look like? It might be some sort of political activation or something like that. It might just prompt another conversation, but really empowering them that they have purpose, how to help them move forward. If we're talking about specific symptoms, getting back to, talking to them about treatment and about care, and again, providing resources if that's the case, understanding what their experience is, if it's something like that, not wanting to get care from something like the VA, just kind of understanding that, but really meeting them where they're at, and showing that safety, that you're a trusting person to talk to, that you are listening to them, that you're providing support, that you're looking for resources, and really doing that in a non-judgmental way.
Thank you. The next question we have here is for Monique. With the hierarchy and rank status, it can be very unfamiliar for civilians. What are some tips to approaching emotionally sensitive topics with officers cautiously?
Thank you for that question. So as a hospital corpsman, I worked with officers. I worked with physicians and surgeons, and a lot of times things came up where you'd have to probably take them to the side, and with all due respect, I would always lead with that, and just say, this is what I'm seeing, sir, ma'am. I have an issue, frankly, with this or that, or I feel like, I'll be specific. I saw a trend of African-American males coming into medical in our acute care department with hypertension. And I would see that some would have labs drawn and EKG done or chest x-ray, and then some wouldn't. And I felt like, well, why is there a disparity? Why is there a difference right there? Why is it that one group of people get these services where someone else is not? And so I just had to be very direct. And so you always want to do it with respect, but you always want to make sure that you, I guess you could say, have your facts together as well when when you discuss a sensitive situation with a leader. Just as you would if you would go to speak with your congressman or senator, you carry yourself with respect, but you also want them to know that you are advocating for a certain situation, and though no disrespect is intended, but you're seeking knowledge and you're seeking perspective depending on whatever the situation is. And that's just my 2 cents. Thank you.
Thank you. The next question we have here is for Sazha. What's the difference between awareness and knowledge under multicultural competence?
For awareness and knowledge, they are, one is actually the education, right? The education, learning what the culture part, the beliefs part. And then when you're actually in practice, when you're sitting with them, what does that look like? So being aware of what the practice actually looks like. So it's the educational, and then actually sitting with them and what does that show up with? Just like, for example, we talked about veteran communication styles, and what it looks like you being aware that it may look like them showing up as reserved or aloof or not being willing to talk about their emotions. That to me is the awareness part, and the knowledge part is more like, okay, I read this in a book, or I learned about this in this presentation.
Thank you. And the next question we have here is for JoEllen. Let's see here. What are entities such as AFW and the American Legion, and are these good resources for veterans?
Yeah, that's a great question. And I appreciate there's so many good questions. It's probably hard picking which ones to even start with. So there are so many, it really does depend where you're at, but like national organizations like the VFW and the American Foreign Legion, and these are really can be helpful in any community, but just to be aware of what your local resources are a lot of times. I'm a proud card-carrying member myself of a few of these, and I really find that they're very helpful, that they're a place to for veterans to get together, to talk, but they have lots of resources about things like disability. That's one of the first things that they say is do you need any help with any of these things? Do you need any help getting connected to care? There's a couple other people who actually wrote about things, and I don't know if that's a national campaign, some of the things that are in the Q&A, and in the chat, but other mental health and suicide prevention campaigns that have been started by those kind of organizations. So really, really helpful organizations. I would always say to find some kind of connection. And honestly, because there's a few, if one doesn't really fit, it might be that you want to use, try a different one out. And most of them offer at least the first year free, so you can kind of go to meetings for free and try it out. So just being mindful and aware of the different organizations is the first step.
Thank you. And the next question we have here is for Monique. For hospital discharging planning, does the military have anything or the VA have anything like that in particular, like we do in the civilian sector?
Yeah, so when a member is leaving service, they attend, or they're supposed to attend, it's called TAPS. It's a Transition Assistance Program, and it kind of prepares them for transition as far as their medical and what benefits if they're retiring or whatever that is that they're privy to. So usually in TAPS, they'll have a medical person or a person that represents medical talk about VA disability claims, the things that they need to get on hand so that they can start their disability claims 90 days before they even separate. So you can actually start that compensation before you get out. They also talk about, I believe, when I came out, housing options and things to think about when you're transitioning. If you were living in base housing, what you need to do, leaving base housing, now trying to go into civilian housing. Also the chain of command, like your chief. I was Navy, so it's chief for me, but talking with them, and they usually guide you. Hey, it's 6 months out. Have you done these things? Hey, it's 3 months out. Have you done these things? And so your chain of command really should be working with you as you transition. But if not, that's what the TAPS class is for, to help link you to resources as you transition.
And the next question we have here is for Sazha. Many of the veterans I've worked with experience high levels of homelessness, which exacerbate their mental health and substance use. What resources are available to them through the VA?
There is the HUD-VASH department, which is where social workers and case managers work to assist veterans who are unhoused. And there is a national 1-800 number for homeless veterans as well. So there are dedicated services. Veterans can also go right to the ER for a housing assessment. And there are 24-hour kind of shelter and transitional housings, different levels of housings and housing vouchers available for veterans as well.
The next question we have here is for JoEllen. How can healthcare institutions support nurses in managing the emotional toll of caring for veterans with PTSD?
That's a great question. And honestly, I think that it's not just about caring for veterans. I think that there's an emotional toll that goes along with healing and caring and being a nurse in general. And I think a lot of organizations have, I think COVID really shone a light on that. I think in our profession that a lot of nurses are struggling. We have a lot of literature now about high rates of burnout and depression and PTSD. That it's not that weren't there, and suicide in nurses. That it's not that wasn't there before, but that it's just become more kind of mainstream. And so there's a lot of organizations like ANA, the AONL, and the American Psych Nurse Association, and ISPN, which is the International Society for Psych Nurses. Lots of different nursing organizations have done a lot of different things, and the American Academy of Nursing, I would want to mention, to really look at what are some of these organizational, because this really is it's so multifaceted. We'd need a separate presentation, so that might be what we want to make sure to. I think a lot of these things that are being mentioned are good ideas for us to put resources on the new website that's coming out, but that would be its own presentation to really talk about these different factors and how to really talk about that emotional toll. But a lot of it, relates to things like workplace violence, and staffing and other things that are really kind of beyond the scope of this. But I just wanted to mention that we do acknowledge that it's not easy being a nurse, and we're here to. I mean, that's why we're doing something like this, to support everyone out there. So I do appreciate the question.
And I'm actually going to take the next question that comes from Susan. At the VA, what is the difference between the PAC social worker and the mental health social worker regarding how they help the veteran? So when I worked at C.W. Bill Young VA Medical Center, which is in St. Petersburg, Florida, I worked as what was called the psychiatric officer of the day, providing cross coverage between multiple different parts of psychiatric consultation. And part of the work that I did was with primary care mental health integration. And so I worked very closely with the PAC team, the Patient Aligned Centered Care Team. And that's really the primary care setting, and it's the patient home where you have the medical provider, you have a registered nurse, you have an integrated social worker. So that's the PACT social worker that works in the primary care setting, where a mental health social worker would primarily be working in what we call specialty mental health care. So it'd be a referral over to the specialty mental health care clinic, whether it was at a primary, a VA medical center, like a hospital center, or if it was out in the community, what we call community-based outpatient centers, or CBOCs. And mental health social workers are primarily going to be working in that specialty care setting, typically providing psychotherapy services and evaluation and treatment, where PAC team social workers are going to be working more in assistance in primary care. And if anyone would like to add to that, who's worked also in VA, please feel free to jump in. Just looking through the questions here and see. For Sasha, working outside the VA, what do we need to know to provide seamless care? It's not always easy to share information or at least see what's happening with their care in the VA.
I would say the VA says the same thing about outside providers as well. So I know this because our systems aren't integrated yet. I know the VA is working on electronic health records to integrate into community providers, which will definitely help the continuity of care. It's really just being able to recognize what is available at your local VA. So, for example, VAMC is the medical center and it's a hospital. If you live in a rural area, you may live next to a community-based outpatient clinic, which is a CBOC, and those are smaller, have less providers, and may only have one provider, a therapist, and a case manager. So really knowing what's available to you and also what is available to veterans. So at where I work, which is an outside program, we treat veterans with private insurance and through VA benefits. So they utilize community care referrals, and that happens when VA is unable to meet the need for the veteran within a certain time frame and have to refer them out to outside program. And that also is still approved by VA, but again, another system that requires some knowledge and working with to know what's going on. So knowing what's happening at your local VA is really important.
And the next question I have here is for JoEllen. When will veterans care be included in nursing school curriculum? When will there be veteran care certification, and how will a civilian nurse or provider be actively involved in those forces? So 3 questions in one from Magdalene.
Yeah, well, thank you. I saw a couple questions about that. So I do want to mention that there is an Association of Military Veteran Nursing, which doesn't mean you have to be military or a veteran. It's really just to start providing that care. And the team is looking at certification, again, just like another type of certification from one of our certifying bodies on military veteran nursing. So any nurse could do that. Now, the other part of the question, and again, that's kind of in the works now, and it's an amazing team, and that's definitely something that you can be a part of. You can learn more about the Association for Military and Veteran Nursing. But the other piece is asking about education, and there are a couple of programs out there, of course. In my program and programs I've been in, we can kind of see the little pieces, but part of creating a standardized some sort of standardized really credentialing or certification exam for that type of nursing would be to really kind of start influencing it to be put into nursing programs. And so that's something that is, I think, very important. I think that everyone ends up seeing veterans. You may or may not have an idea if they're veterans, but I think that everyone ends up seeing them. So it's an important thing to understand. I think the Have You Ever Served campaign, like we mentioned, has a lot of really great resources. Some people had asked more specific questions about Agent Orange and other things, and there actually are there's specific information about that, about some of the legislation, the PACT Act, and other things that I'll point you to that as a reference, because I think it's a really good reference, kind of in general. And I think that we're working on it, is what I would say about that. So thanks for the question.
And there's a follow-up question for Sasha. When you say the veterans can go to the ER for housing options, is that a VA ER?
Yes, that is a VA ER. Sorry for the misclarification. And from there, they can refer them to the HUD-VASH department, which I had shared with you all, and get them connected to resources.
And this one's for any of the speakers. Have any of you found differences in how those seek care, active duty versus reserve or National Guard, and how they seek care as veterans? I think there's some difference in eligibility. Is that correct?
Yeah, I
Yes.
mean, I'm happy to answer that. There's a lot of difference in eligibility, and a lot of times our National Guard and our Reserve don't feel as supported because when they come off of active duty, they don't have the same access. So really looking at that. But I mean, it's kind of hard it really depends on what service we're talking about, and it depends on what branch and what service and kind of what their experiences have been. But that doesn't mean that again, that you can't at least know what resources are available and kind of point them in that direction. That's maybe the short answer, because it would be a very long answer if I didn't just kind of say finding out some of those resources and helping them get there. And if whatever anyone else has to add.
And I really would like to thank everyone for their wonderful questions. There really are quite a few more, and I'm going to be reviewing them afterwards, and we're going to work on making sure that these resources will become available on the Caring for Veterans webpage that will be launched this next year. On behalf of the American Nurses Association, I would like to thank our distinguished speakers, Dr. JoEllen Schimmels, Monique Swaby, and Sazha Alexandra Ramos. We are profoundly grateful for their service to our nation and for advancing our knowledge of how to care for veterans navigating mental health challenges. For those who would like to follow up, our speakers have made their contact information available on this slide. We are thankful for our speakers for their meaningful contribution to the American Nurses Association Veterans Health Initiative. We'd now like to acknowledge the sources that inform today's presentation. The following forward slides contain the list of references used throughout the session. These materials reflect the evidence base and resources cited in this webinar. On behalf of the American Nurses Association, thank you all for attending and engaging with us today. We truly appreciate your time and your participation. And thank you for helping to care for veterans.